Well, now we're back, and I'm Dr. Shelley. This is acute coronary syndrome part 2. If you'll remember the introduction to acute coronary syndrome, we talked about the patient coming in with the chest pain and some of the risk factors that they had. We talked about the fact that the patient could be smoking, it could be cold weather, it could be exertion, it could be sex, it could be exercise, it could be somebody died, they had a fight with their wife, whatever it is, it's a big deal that you remember they had some risk factors coming in. The same is true with the next part of this lecture. If you'll recall also when we talked about acute coronary syndrome, we focused that first part of that introduction on the MI patient, also known as ST elevated MI. And the ST elevation MI had to do with the actual EKG. Okay, so now we still need to focus on pretty much all of those things, but instead of looking at an ST elevated MI, we're going to take it to a different direction. That patient, what did we do? We gave that ST elevated MI patient with the ST elevation on the EKG and the positive troponins, we gave that patient aspirin. We gave that patient an EKG 12 lead within 10 minutes. We gave that patient nitro. We made sure that patient was in the cath lab with their heparin and their weight by 90 minutes, although good hospitals are never going to go that long with it, and I work at the best, so we get our patients in under an hour, just saying, average. Sorry, sometimes the excitement about working at one of the best cardiac centers in the world gets to me. But what I'm saying to you is that was for the MI Stemi patient. That patient had a certain set core measures that we had to do within a certain amount of time, and we did that. Certainly if that patient came in and there was some reason why there was no way to get them to the cath lab, we would detour a tiny bit and we would still do the 325 milligrams of aspirin on arrival. We would still do that EKG within 10 minutes. We would still get that patient nitro and titrate it based on their pain scale. We would still get them appropriately oxygenated if their oxygen level was less than 90. We would still get that 18 gauge IV, probably in both limbs, as well as troponins and other labs ordered. But the difference would be that we needed to do something where the cath lab wasn't part of it, but medication to dissolve the clot was. So if you're not going to send the patient to the cath lab, then we're going to go ahead and have to send the patient, or not send the patient, but treat the patient with the medication that would dissolve the clot. The medication that would dissolve the clot is called a clot buster. On the street, you ain't on the street. You right here with me as a nurse or a doctor or a PA or a nurse practitioner, and so you are thinking and talking differently. It's not a clot buster to you. That's how you describe it to the patient. This is called a thrombolytic or a fibrinolytic, either TPA or streptokinase, some type of strong medication to break up that clot and that obstruction in the coronary artery or some other part of the heart. What's important to remember is it's either or, not both. No, 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 no. If the patient comes in with a Stemi, ST elevated MI or ST elevated on the EKG heart attack, then the patient needs to go for a cardiac cath to the cath lab. If they can't go to the cath lab, then you are going to prepare a thrombolytic, also known as a fibrinolytic medication that will dissolve the clot. Generally speaking, the old-fashioned terminology, if you will, is TPA, but a lot of times we don't use TPA. We might use streptokinase or some other type of medication that ends in ASE because it's an enzyme, ASE, remember, that breaks up the clot. Now, put that aside because that was all for the STEMI patient. We need to look at what happens if there is no ST elevation on the EKG, but perhaps the troponins are showing some damage to the heart. And remember what's happening. Oh, excuse me. I'll be right back.